στο YouTube, εντάξει.
Όχι, δεν με πειράζει, απλώς να φτιάξω λίγο το background.
Κάνε και mute. Κάτσε background σου και πες μου πότε παίζει να βγάλω στον αέρα.
Περίμενε. Hello, dear Wolf. Hi, are you?
Microphone. Hello. Hi.
Hello, how are you?
Oh, I'm fine.
Nice.
Yeah.
We just
So-
testing, just open it to test how it works, because most people will be through YouTube. They will join, but there are a few who are already in Zoom. The Zoom we kept the Zoom for ourselves. Somehow.
Yes, that's fine.
To be able to discuss, but there seem to be some people who also liked to see the preparation, so we are public now on the preparation. How are you?
Yeah, I'm fine and prepared to have an interesting discussion with you.
Okay. Okay. Do you want us to test the share screen? Do you have the data on PowerPoint? Do you want to have a test or not?
Yeah, we can do that. I will share my screen now.
Yes. We don't need it for the whole time, but just to be ready whenever. That is a nice screen, Professor Malm. Really, everything very tidy.
Seems to
I will share
work.
my screen at the end privately. Great, great. It works great.
Yes.
All right.
Then I stop sharing.
Yes, please.
So,
I think we can share the invitation at the moment till we start. Fotis is a colleague. He's also elected in the in wapr, and he's a clinical psychologist also.
Hi, hi.
hello. Hello.
And
Hello.
although he's a clinical psychologist, he will help us with technical details.
Uh-huh.
He has
Hope
two
you don't
skills.
need to work.
Yes. There are some people, they have more skills.
Yeah.
True.
Thank you a
So,
lot for this webinar.
What?
I would suggest to have 5 minutes before starting.
Yes, and I thought in the beginning, before I introduce you, I say a couple of minutes, some things about wapr International. And then I introduce you, okay?
Yes.
Thank you.
So my idea is that I will start with a few introductory words, and then you take over, and then I will go for my PowerPoint a little later.
What do you mean by that? I followed the plan you said. So I'll talk a little bit about wapr and explain what wapr is and how it works and its
Yes.
goals. And then I'll introduce you. And then sometime after that, I will, after you say about the frame of your speech,
Yes.
then I'll say some words about the Falun and OTP.
Yes.
And then you proceed on with the procedure, and I'll be in between and do the conclusions at the end.
Yeah, and sometimes you told me that you must
Yes, and sometimes
translate
to put
agrees.
some questions in between.
Yeah.
I'll try to pose up questions, and if there come questions from the people listening, I'll include them. I mean, if there are some questions at the end, we can make questions and answers at the end. But if they are
Yes.
in the content while you speak, and I think that they would help your presentation or discussion, I may interrupt you and pose the question in between. I mean, it's okay.
Yeah, that sounds wonderful.
Have it a little more active, probably. Very nice.
I have a
Matthias is
question.
very light. I think Sweden is a bit darker at the moment in this Zoom.
Yeah. I wonder about this one. I think it was so wonderful. This with the blocks. How did you?
Yes,
how
I
did
thought I put it now. That was my idea.
who has done it? And how did
Yes.
you get it? It's a very good illustration of the things that I will talk about.
Fotis made it. This
We can
illustration.
share, Professor, we can share the secrets after the webinar.
Yeah, Fotis has the secrets of this. But now we are in public, so we'll discuss it afterwards.
Yes.
Yeah.
We are in public in a YouTube channel.
Yes. Nice. So I think we have a couple of minutes more. So most people will join through YouTube because we publish the YouTube address to have it easier in mainstreaming. And we keep either Zoom or for our exchange. We'll wait 2-3 minutes and we start, huh? What do you think?
Yes.
Yes,
Well,
Alexander, I think it's okay.
Mediterranean sharp. 3-4 minutes delay.
Professor Malm, do you also have the academic quarter, as we say in South?
That I didn't catch. What did you say?
Do you also have in Sweden the delay of the academic quarter?
Yes, the delay, the academic quarter. Yes, we have. We have, yes, surely.
Perfect.
But we won't keep it in Zoom. We'll start in a while, I think.
Yeah, academic quarter, yeah.
So I think we can start. What do you think?
Yeah.
Yeah.
If you ask me, it's yes. Yeah.
Good.
Yeah.
So I'd like, good afternoon to everybody. I'd like to welcome you to this webinar held by the Greek branch of the World Association of Psychosocial Rehabilitation, wapr. Maybe you know wapr, you are familiar with that. Mental health professionals working in psychosocial rehabilitation are usually familiar with this NGO. It is an organization, international organization.
Sorry, Alexandra, maybe you can stop sharing to have you on the screen.
Yes.
Perfect. Thank you.
Okay, we're fine now. Huh? Okay, so wapr is an international organization founded in 1986 by 100 mental health professionals attached to the WHO, and they founded this organization with the purpose to promote everything around psychosocial rehabilitation. And nowadays, wapr is composed mainly by interdisciplinary mental health professionals of several faculties, but also with people who profit from mental health services, and also by their families and the wider community systems who can be included in the recovery process of mental health, of mentally ill persons. And that's about these wider systems in micro level, in ecological level, on a wider level that our guest, Hoyte, will talk to us. I think it's important to keep in mind that the mission of wapr is the dissemination of the principles and practices of psychosocial rehabilitation and recovery, and that service users are valued as important members, as experts by experience. That's why we have also in the delegation of the international NGO, as also on the national delegations, always equal participation in decision-making of families and of patients. In Greece, we have a national department since many years, at least since 25 years. And in these national departments, at this time, we try to disseminate knowledge and education on this topic. And that's how also this webinar is held. I wanted to say it here that the participation of Greece in this whole movement of rehabilitation has been, since the beginning of wapr, a very important one, with some important professors of us being represented in the European or in the worldwide organization. So we had scientists honored, like Professor Michael Madianos, who has been earlier a president of the international organization. And then we had Professor Stelios Stylianidis, the founder of EPAPSI, the NGO who is co-organizing this webinar today, and who was the vice president of the European department, and Professor Economou, who at the moment a very active professor in psychoeducation, who is at the moment vice president of the international association. And we also have the psychologist Michalis Lavdas, who is a regional vice president for Europe at the moment. That means Greece, though small, is very active in all this progress towards inclusion of patients, of severe mentally ill patients in the community, of keeping patients in the community, and of supporting the families to achieve the care more effective and with more education. To serve this mission, wapr does several activities like promoting policies, international exchange of experiences, consultations to local and international agencies, as also to WHO, or promotes the open dialogue among consumers, policymakers, and professionals, research on innovative approaches, and of course, it organizes educational webinars and educational activities like this one to spread the latest knowledge on psychosocial rehabilitation. So we have today the opportunity, the luck, I'd prefer to say, to have with us the Associate Professor of Psychiatry at the University of Gothenburg in Sweden, Professor Malm. I'd like to welcome you, Professor Malm, and just mention for you that you are a person, a scientist who combines the experience of the practice as a clinical psychiatrist, as also a long work as a faithful researcher. And this combination makes you a valuable expert in theory and practice in the field of severe mental illness. I may welcome you and ask you to present us the content of the webinar today, please.
Thank you, Alexandra. Do you hear me well?
Yes.
Yes, I'm a psychiatrist and neuroscientist too. And yeah, as you heard, my name is Ulf Malm, and in my whole professional lifespan, in fact, I've been engaged in doing research to improve treatment of severe mental illness. And then we go to the basic for this webinar. During 2022 and 2023, the Swedish Committee for Treatment and Care in Psychiatry organized a series of web seminars focused on how to improve treatment for severe mental illness. And many researchers from many countries participated. The empirical ground, yeah, they exchanged opinions and facts. I can add that the empirical ground is vast. It's both quantitative and qualitative studies. I will just mention that out of 19 outcome studies, 7 were randomized controlled trials.
All run in Sweden?
That in Sweden was a randomized controlled trial, yeah. And as I said, the studies were carried out in various welfare systems and different cultures. Most of the patients in the studies suffered from schizophrenic disorders. And important, the durability of the randomized controlled trials was from 18 months to 5 years. I think Alexandra later will introduce a little Ian Falun, because his idea was that at least 2 years or almost 2 years is necessary to understand if initially achieved improvements have the duration. Then I will introduce some concepts. One major component in the optimal treatment project was a family care unit in the community. I will come back and explain a little more. That is a kind of microsystem that was developed in collaboration with Ian Falloon into a resource group clinical microsystem. And I will tell you more about that too a little later. And most important, I think, the discovery of the web seminars was that we found a pattern of knowledge. Patients' outcomes greatly and significantly improved when you delivered science-informed service by clinical microsystems. So very short, if you use all the knowledge that you have and put it in a basket, clinical microsystem, then you achieve much better outcomes. We might discuss how that is possible, but some mechanisms that play an important role is psychoeducation in a recovery frame and patient co-production within the microsystem. A microsystem, according to the definition from Dartmouth, who has made a lot of research on this, consists of the patients, family members, other resource persons, professionals. They all work together. But what is very important is that there is also an inbuilt communication system and follow-up system. So let us leave the micro level and have a short look at the macro system level, because if you use the perspective of improvement science, it seems that digitally supported learning health systems, I will come back to the concept later, and learning health networks might further improve the outcomes. Well, I think that was what I wanted to say as a frame.
Of the frame of the discussion of the webinar, yes.
Yeah.
Mm-hmm.
So I will come back.
You said two core components, psychoeducation and patient co-production, that we will talk about, and microsystems. Yeah,
and also empowerment of the patient. I think it is an important idea that has to do with as present often there is an asymmetry in power between patient and professionals, and so I might add empowerment of the patient.
Yes, I think this I could say two words about Ian Falloon, because maybe not everybody is familiar. Ian Falloon was a professor of psychiatry, and he was the pioneer, or one of the pioneers of a group of professors at that time in the UK, who developed the model of psychoeducation. And the very special about Ian Falloon and all the group involved in Maudsley at that time was that they tried for the first time to include the families as collaborators, as co-productive, I would say, if we use the term of today, co-producing the therapy plan. So it is at this time that we start to see the families as persons who need education, who need support, who need a special help to create a convenient environment as to keep the patients in the community. So he developed a comprehensive model of psychoeducation, which does not just include education, as many times people think, but it includes a lot of more interventions which are changing the knowledge, the view, and the relationship between the family. And Ian Falloon's approach through psychoeducation was and is still an avalanche to change in the way we treat mental illness, in the recognition of the patient as an expert, and the inclusion and advocacy of the family, who are the actual carers 24/7, and they have certain needs which we can address and answer. Besides that, or to include that, Ian Falloon was also a pioneer in dreaming, I would say, how recovery should be in an idealistic way. And he developed a big research project called OTP. OTP was an optimal treatment project, and I think there were about 35 countries who were included in that project, where they tried to, all the participants tried to implement in their services some optimal treatment factors like lower medication, like involvement of family, like psychoeducation, like vocational rehabilitation, like inclusion of the wider system, sport groups, communication group, community groups, cultural groups, etc., as to help the patient to stay in the community. And simultaneously, through this project, was all this measured. And the idea behind that was that if we apply the optimal treatment and we measure it, then we can prove that it is really effective, and that we can, with lower medication, approach a person with mental illness in his several various needs and give an answer to it, and keep him in the community as an equal person and as a partner in our discussion. So in this optimal treatment project, the University of Gothenburg and Professor Ulf Malm was one of the major participants, as was the first psychiatric clinic of the University of Athens with Professor Marina Economou and me. We were also participating and collecting data for over 5 years for this big project. The data was collected and partially published because the project was has stopped in a certain moment when Ian Falloon was not anymore in life and could not go on with the project. It was abrupt, broken, but some of the data was collected and published, the smaller part of it, but the idea of ODP was spread internationally, and group of professionals on that time are still active in this direction and form further groups, like the group that Professor Ulf Malm has formed for 2 years, which is trying to spread these ideas broader and to include also other aspects like patient co-production, and to train professionals worldwide on this. Dr. Malm, Professor Malm.
Okay, then I go on, and I will show you then a series of PowerPoint slides. So to start with, I will share.
Excuse me. I think it must be a little louder. I'm not hearing very well. I don't know about the others.
Louder?
Yes, I think a bit louder, please.
Yeah, I try to speak a little louder.
Thank you.
That's very good. Just point out if it's too low, then I speak higher.
Mm-hmm.
Well, then I share my screen.
Okay.
See, that is the first slide, but
It's shared. You can see it.
Yeah, but you see, so
now it is full screen.
yeah, and
Yes.
now it works. Yeah, it works.
Now it's okay. Now it's okay. Yes.
So I think the model of patient co-production refers to what Marina has already told us, that you collaborate with the patient. I have met some colleagues who thought that patient production referred to that patients collaborate, which of course they might do, but this is the collaboration between the patient and the professionals. So here I repeat what I said in my introductory frame, that we discovered during the Zoom web seminars that all the data, all the facts, all the information, all the clinical expertise that is hard sometimes to recognize, but we could see a pattern. And the pattern was that patient outcomes improved significantly when science-informed treatment was delivered by clinical microsystems. So we have a method that is proved to be both effective and improve quality of life, effective on social function, effective on symptoms. Then I think that I will just tell you a few words of the participants in the web seminars. And Alexandra has already mentioned the veteran scientists, researchers from the Optimal Treatment Project. And that was focused on integrated care, a program constructed for the Optimal Treatment Project versus the best practice in many countries. And that project was carried out between 1994 to 2011. Then some years ago, 5, I think, I was contacted from the Netherlands, from a group that was interested to understand and learn about how we did integrated care in Sweden. They were very interested, and that initiated a randomized controlled trial where they added the new method, the resource group method, delivered by flexible ACT teams. That's a Dutch specialty. So they did a randomized controlled trial, which we can say in one way, it replicated the findings from the UTP, from the Optimal Treatment Projects, by quite independent researchers. That, I think, is strong evidence for saying this works almost anywhere. And the secret has to do with the with a microsystem, because the microsystem is composed locally. So it includes automatically the local habits and local aspects of life and cultural factors. And then it was very interesting that the way of mind, or us in Sweden, where we had discovered what we call the resource group, the microsystem, we found out that in Dartmouth, in the United States, they had since about 20 years done a lot of research on what is effective for high quality organizations and service and healthcare organizations. And they found that the common denominator is clinical microsystems. So fortunately enough, also in the web seminars, some representatives from the Dartmouth research projects could participate. So in fact, it was a fascinating and interesting cross-pollination between various different research groups, both in present time and between the past and today. Do you want to interrupt or explain something, Alessandra? You are muted. We cannot hear you. Alexandra,
Κύριε Πάλι, δεν σας ακούμε.
Sorry. I was talking alone, sorry.
Yeah.
I thought it would be maybe interesting if you could tell us something more about what were the results of the Dartmouth project. If you have more information, how did they apply microsystems, or will have any results, or about the Netherlands project? I think it's interesting to know some more things in detail about them.
Yes. First, when the optimal treatment project is concerned, we made a meta-analysis that was comprised of, I think, 18 studies, 11 observational studies, and 6 randomized controlled trials. And the outcomes were put into 3 baskets or categories: symptoms, function, social function, and well-being, which is about its quality of life. So the major finding was that there were large effect sizes for improved social function and for quality of life, and moderate effect sizes for improvement in symptoms. And the interpretation was that almost in all the countries that participated, the medication, the treatment with antipsychotic medication, was rather well developed. So we think that what concerns symptoms, medication is probably one of the most important treatment methods. When we look at the Dutch project, I think they had about 150 participants, and they looked at not only at symptoms and social function, which symptoms improved, well-being and quality of life improved, but they also, as a special interest, was looking at empowerment. measured by different scales. So they could also one finding was that also the empowerment of the patient increased significantly. So first, in general, the Dutch randomized controlled trial replicated the optimal treatment outcomes from the meta-analysis. And they had moderate effect sizes, may I say.
In quality of life. In quality of life.
Yeah, yes. So what I added was, as I said, a measurement of empowerment of the patient. But I also did another thing, they did a qualitative study that also you can read about that if you want in a thesis by Kathleen Chaden. Her name is mentioned later in my slide presentation. And therefore, the thesis is called simply Working Together. And I think working together is a win-win situation for creating relationships and for both patient, family, and professionals.
That, if I may comment, that reminds me a little of the change in psychology in generally. I mean, all the shift in the beginning, the whole effort was to try to eliminate the symptomatology in severe mental illness and to develop medicaments to eliminate this. And it's still going on, this effort, with always better results, but there's still work to be done. But there seems to be a shift in this, and then we stop just trying, like in psychology. The initial ideas in the past decades was to develop psychotherapies and models and interventions which could eliminate symptomatology in anxiety, depression, and neurotic symptomatology. But I think the last years there's a shift in this, the last 20 years at least, where we are not happy anymore with stopping symptoms, but we try to achieve a quality of life and to empower people to live a meaningful life. And we see that in psychology through positive psychology, but we see it also here through the whole shift where we still have the symptoms, we still have the medical treatment, which is a core treatment in severe mental illness. We cannot do without it. But our main focus starts to be, in the last decades, how we can help these people live a meaningful life in the community, not just eliminate the symptoms.
I think you're quite right that there has been too much focus on the idea that if we just can reduce symptoms, then the patient can live a life. It's not so. So therefore, I think the recovery concept is so good. The idea that even if you have certain symptoms, you might learn to handle them together with your resource persons, and you can live a good life.
That reminds me of some patients I've seen where they are very functional, they live their life, they work, I mean also schizophrenic patients who work fully, and they still have some symptoms, they still have some voices, but which are in a way, they can handle them through medication, of course, but also through their management. So that doesn't really inhibit them of living a life.
No, it's also so that if you look at the microsystem, which I call the resource group, they are so familiar and know the patients so well. So in periods when the disease increases and patient might not communicate as good as usual, then other people from the resource group can support. And that seems to work in almost any critical situation. So if we summarize just that has to do with the recovery concept, that you might improve your social function and quality of life, despite maybe persistent symptoms. Of course, it is, as you said, possible to reduce some symptoms by, for instance, psychotherapies. And of course, that should be used. I will show that in a slide soon. So then I go on?
Yes, please.
And here you have the Dartmouth definition. Is this based on the, they have not worked with mental health care. They have worked with healthcare in general. But a mental health care clinical microsystem can be defined as a small group of people, as I mentioned, the patient, family members, next to kin, and professionals. And they work together to co-create services and treatments for people who must deal with life and living problems due to severe mental illness disorders. Good. This meeting is being recorded. Yes. I have forgot it. So this is very important. The microsystem is, of course, embedded in other systems. But furthermore, it has a person-to-person and digital communication system, which is essential. For instance, one thing that we didn't have in the optimal treatment project is the ongoing self-reporting of mental state and quality of life and so on that the patient might do. Patient-related outcomes is one way for the patient via a digital communication to tell the doctor or the case manager how does the process work out. I will show a dashboard later that was used for the doctor and the patient, or for the case manager and the patient, to understand if things are doing well. I'll show a slide a little later on that. So here we have, in fact, Alexandra has already told us this. I will just add or point out the assertive case management, the ACT concept. And then I point out the two last lines, lowest lines, that the microsystem used in the most of the studies in the optimal treatment project was the family care unit in the community. That's a quote from Ian Falloon. And the developed the family care unit, the resource group microsystem, that was applied in our randomized controlled trial in Sweden and also in the Dutch study. And here is just a few data on what we have today. We now have 19 outcome studies because the Dutch study is added, so it's now 7 controlled trials. There is also a new observational study from Japan showing that also people which is older than 60 years can benefit. Because most of the other studies has been made with people, as you know, when you select people for clinical studies, often there is a span between 18 to 60 years or something like that. So the picture also tells us that the randomized controlled trials were carried out in Norway, Italy, Spain, Japan, Turkey, and Sweden, and the Netherlands.
Mm-hmm.
And here I think that is a slide that summarizes the meta-analysis. Symptoms moderate, effect sizes.
Which, if I may interrupt, it's different as psychoeducation, because here we have moderate size affecting symptoms, Well, with through psychoeducation, we know that we have major effects in relapses, that we have a major reduce of relapses. And if we have relapses, or when we have relapses, that the symptomatology is not so intense, and it's not so, doesn't have such a long duration as without psychoeducation. There we have a really higher effect sizes in symptomatology. But here we have, as I see, in social functioning and in well-being.
Well-being, or some people call it quality of life. Mm-hmm. But how should I put? Well, I come back to that later. I think about. I will tell you a few words about certain patients. So the most important, you can read yourself, but the most important point here is that it seems that this patient co-production in clinical microsystems can narrow the gap between what we know and what we do. It is well known that one problem in all treatment, not only in psychiatry, is a low program fidelity. People sometimes do their best, but they cannot take their medications at the right time in the right doses. They sometimes miss psychotherapy sessions and so on. So what is so interesting and important is that if we look at the Dutch study, there is no new magical treatment methods. It is just so that if we use all that we know, it seems to be the reason for why the patient outcomes improve significantly. Because within this small resource group microsystem, there is support and checking for all treatment methods and all agreements and all goals that you have. So it's so interesting for me that we don't we can achieve these outcomes without a new miracle medication, for instance. So I think the sentence that the outcome of this was that patient outcomes improved significantly. That we could observe. That's an empirical fact. Sometimes Alexandra and I talk about hard facts and soft facts. I will come with some soft facts from a patient later in my presentation. But we have a look at this. This is a very interesting short paper in British Medical Journal. I mentioned that we had in the web seminars the luck to have a representative from Dartmouth to lecture, and that was Paul Batalden. And one of the most important messages in this paper is that we often look at healthcare as a kind of production, in production terms. It is not at all production. It is a kind of service that is based. He mentioned an example. If a manufacturer of cars should try to sell you a car, first they manufacture a car, and then they have to convince the customer. In healthcare, you cannot do it that way, because then you neglect personal preferences. You neglect the life situation of the patient. So it is necessary in healthcare that there is a collaboration, a relation. You cannot just make a ready-made program or a ready-made medication and just tell the patient, use this, do this, and especially not for those people with severe mental illness that has so many problems to struggle with. So here is described what patient co-production is, and it was interesting because it was almost viral, this paper. It was spread in millions of quotations over the world, but I think we go on. And here we have a few aspects on the mechanisms of action. As I already told you, we have a recovery frame. You might become better. You must live a better life. It's possible, even if you have some symptoms left, some residual symptoms. And here I think psychoeducation is so important, not at least to handle emotional problems connected with disease or disorder, severe disorders. For instance, one apparent thing is that many people has talked about this, the stigma of how to handle that. And here is the name of the Dutch researcher Kathleen Chardin and her thesis, Better Together, which I think those who want to can read on the net. And both the... What?
Nothing, it's a disruption. Go on.
Okay.
Somebody forgot his microphone. What she concluded was the empowerment of the patient and the family in that qualitative study that confirmed what was the clinical expertise. And as I told you earlier, one important component is the co-production in clinical microsystems. May I ask something? When we say clinical microsystem, who do you suggest should participate in these microsystems? I don't know if it's so clear.
No, but it is, of course, the patient, and then is members from the family, can be one, can be two. I had a resource. I was doctor in a resource group where we had both father and mother and a sister and a brother, in fact. So so they constituted almost 1/3 of the resource group. And then sometimes patients prefer not to have family members in the group because sometimes they think that parents dominate too much. That's the opposite. And they instead want to have a neighbor or a friend or two. For instance, Annika, who I will mention later on, she had a very large resource group. We used to meet at her home, and there was about 12 persons. And that was interesting because one of her friends was a psychologist, but he was not there as a psychologist, but as a friend. Mm-hmm. And then it was her mother, because as is usual in Sweden, people divorce. So her father has moved to Stockholm, and we had this resource group in Gothenburg. So in Annika's resource group, there were only her mother from the family, because her brother was living in Stockholm. But interestingly enough, her brother was a documentary photographer. So he, in fact, made a movie about Annika, but that is in Swedish, so I cannot show you that now, on what happened to her when she recovered, because she did really. We can go back just...
And who else can participate? Can mental health professionals participate in the microsystem?
Yes,
Case managers or the community people?
Yes, it is so important that they do. Both people from
here you have the answer. Yes, thank you.
Yeah, and also people from social services. So in an ideal resource group, you have, for instance, if the patient has diabetes, for instance, as a co-morbidity, then it is good to also include a doctor that knows an internal doctor who knows about diabetes. The group is composed according to the needs of the patient. And it's so important, and that's a part of the empowerment, that the patient can say no. The patient has the final word on who is to be invited to participate in the resource group. So we had some complicated situations sometimes when a patient said, yes, I want my mother to participate, but not my father.
Yes, that's difficult then.
Yeah.
To handle.
So my answer is that in an ideal group, you have some family members, you have one friend or so, and you also have some representative from social services. And also, of course, the case manager is a permanent secretary or leader. So it is not the doctor, but the case manager. And the profession of the case manager might often be a mental health nurse, but it can also be an occupational physiotherapist or a physiotherapist or a psychologist who takes the role of case manager. Because when we come to the doctors, doctors often tell everybody that they don't have time. But it is the case manager's time in the first instance. So other doctors have said it is a fantastic gain to have a resource group, because I can work out my ideas and my recommendations, my prescriptions much better. I've got a powerful tool with it. Not only the patient has got a powerful tool, but also the doctor. And the hub in all this is the case manager. Any follow-up question, Alexandra?
No, I'm okay.
So shall we? Then I go on.
Yes, please.
Here, I think we was here. Yeah. What is this? Yeah, it is two persons. I don't know if the blue or the black one is the patient and the case manager, but they are sitting at the point of care, which may be at the patient's home or at the community care unit. And the learning health system has transformed all the data on quality of life, on social functions, on reports by the patient on well-being, into very easy readable graphs. So if you see in the middle of the figure, there is a 3 point of care dashboard, the data screen there. And you can also see to the right, if you look at 4 questionnaires, you can see how we got the patient included in reporting, in providing data that can be used for the planning of the treatment. You see level of functioning, and quality of life. The PROM is acronym for patient-related outcome measures. In the United States, they even have sometimes used the term measurement medicine, because it is then so that the patient, for instance, every third month or more often reports, for instance, his quality of life. On the dashboard, you can also see the care plans. And another thing that is interesting that is created, in fact, in the Netherlands is the flexible ACT model, because, as you know, in the original American concept, all members of the team was always working with all the patients. And that is not at all cost effective. So what the Dutch people invented was a flexible ACT, where in crisis everybody works together, the resources from the whole team. But in other periods, it is mainly the individual case manager who has the contact with the patients. So they also have a triage system for how to switch from individual case management to team case management, which is then the classical assertive community treatment model. So the learning health system, the interesting thing that catch my interest was that as a doctor or as a nurse, you don't have to do anything. You just send in the assessments, and then some kind of simple artificial intelligence converts all the data. So you just got them in real time on your computer screen. Because one of the problems earlier has been that you got a lot of data, but you don't have time to handle them. As you might see, Andreas Gremer made a thesis on this. I was one of the supervisors that was very successfully defended last year. So you can also read that one. It is from the Jönköping University. Andreas Gremer, Learning Health Systems, you will find it. It is usually abbreviated LHS. It is quite a new concept, so there is not fully agreement between improvement scientists exactly what it is. But the idea is that you should not only learn and support the patient, but you should also learn the system, the organization.
You learn to support the system, you mean?
Yeah, I mean, for instance, if you have a clinic or you have a department, the idea is that it should also improve the whole organization.
I think that tries to answer to the question of Paul Batalden, who asks, how can we improve the services? How can we transform the services that they assure quality of care and that they assure that the patients are really gaining the most possible, that the theory comes to the practice practically?
Yeah, if I understand the question right, it is so that all the people in the resource group, they are know very well what is the plan. So the doctor cannot be at the patient's home to see what she does in the morning, but that can her mother, for instance. So you got various situations where resource persons can remind the patient. You support the patient to follow the plans. So I think there the personal relationships is which is sometimes forgotten in today's medicine is so important. So that has to do with what I call the personal communication system within the resource group.
Mm-hmm. There's a question. Somebody's asking if there are any criteria, clinical criteria or other criteria that we have to keep in mind in order to initiate the process of co-production. Is there any special criteria when we want to organize this co-production with users or with their families?
Yeah, I think that one interesting point is that differs from the common usual system, that you first must have a precise diagnosis.
Mm-hmm.
Because here, in fact, you don't need any diagnosis at all, but maybe for the medication, but otherwise it is the needs of the patient that you have to map. So when you have mapped the needs of the patient and informed them about the opportunities and the outcome, the research outcomes, if you decide to go on with a resource group method. So already from the beginning, it is a kind of co-production and collaboration. First, you must inform, that's part of the psychoeducational component, the patient about what this is. And I've seen that patients and also family members, they can very well understand the scientific results. They understand that social function increases. They understand these measures. So, in fact, the criteria are very. You can always start with all kinds of patients. In the Optimal Treatment Project, the diagnosis was schizophrenic disorders, but in the Netherlands, it was mixed of people with bipolar, depressions, comorbidity disorders. So I would say that there is no limitations, there is no criteria that, but the one that you should inform the patient, and the patient should say yes to participate, and then you can start. And you don't need to have a group of 8 or 10 persons. You can start with the patient yourself and someone else, and then you can add other members as time goes by down the road.
And there's another question. Somebody asks, how do we handle it when we have a patient in relapse? Do we include him in patient co-production? I suppose you would say yes. Is it?
I didn't catch the question.
Somebody was asking,
yeah.
How do we handle it when we have a person in relapse, for example? Co-production, or if we have another approach in this case?
You see, the idea is then that of course the case manager and some other persons from the resource group join the patient at the hospital in the case the relapse leads to readmission to hospital. And that also means that sometimes you can reduce both the number of days in the hospital, and you also can increase the trust that the patient have. Annika, whom I will tell you a little about earlier, later, she did it the best way. When she had started a resource group, she had almost no relapses. I follow it for about 25 years. That's the best, the best answer that prevent the relapses. But Annika had one relapse, and she learned a lot from that because she had not followed the instructions concerning stress. She has a low stress tolerance, and she changed her medication by her own because she felt so well. So she thought, I don't need any medication anymore. But I think the important thing is that you're with the patient all the time, when it's good times and also when it's bad times. And then if there is a relapse, the case manager can explain to the people at the hospital what the kind of aspects that the patient think is very important in the care. And they can also assure and support. Earlier it was often so that the family member or the family had all the responsibility. So often we hear that family member says that it is such a great difference for me now. I'm not the only one responsible. We are a team that is working, and it's the same as the patients feel.
I have a family member asking or making a statement that often, the power dynamics between the parties who participate in the microsystem themselves, they're often deeply unequal, and the discourse of psychiatry is dominating. So
yes.
Co-production implies equality, and she's asking, how can we change that?
I see a lot of things. I know it by clinical expertise. We have not researched it, but things change when people meet each other in the resource group. For instance, I remember a situation which I take a rather simple situation. It was the father of a patient we was in the resource group setting, and he said, I think that you should take a certain kind of medication because that minimizes the relapse. And they got the dispute because the daughter said, no, I don't want to, I want to find other ways. And her father was almost angry, and so the other case manager had to support her patient. And I finally said, as a doctor, that here we might try the way that the patient suggests. So we made a plan, which also her father agreed to, that for 1 month we should try the way of the patient during supervision. And both were satisfied, but we also had further psychoeducational individual talks with both the family and the patient. But usually it is so important that the patient becomes so empowered that she or he dares to say no to what her parents tell her. And if you do it in the resource group, you can, I can assure you, can almost always handle it, even if sometimes the emotions get out.
Mhm. And another question on microsystems. Somebody is asking, a colleague is asking, you have this open dialogue approach, which is well spread and
Yes,
have some
yes.
similarities. Do you think there are any methodological relatabilities with the sense of co-production?
Yeah, we have talked a lot about that because that's in the Netherlands. It is has been, in fact, been a great disputes sometimes about open dialogue. But you see, the
yes,
important
in Finland also, yes.
the thing here is that they can work, they can exist together. The ideas can exist together. So I remember I had a lecture once, I think it was in Rotterdam, and one representative from the open dialogue movement came over and said, "This is fantastic. Here we can add we can take both of the methods." And
do they have similarities?
What?
Do you think they have similarities, the open dialogue?
Yeah, some similarities is, of course, the role of for instance, the role of the patient, but also that you work in group settings.
And maybe also the role of the professional, who is not so, he's not so much dominating, he's more equals on the way to the patient.
I presume that you are familiar with that UN report that came, I think it was 2 or 3 years ago, that just spoke about the asymmetry between patients and professionals in general. What was his name? He was from Estonia or somewhere, who was a kind of secretary. But they have a lot of aspects just on that asymmetry between in power between the patient's family, and recommended that they should change, which caused a lot of controversy in different psychiatric associations because doctors didn't agree.
Mm-hmm. I think we can go on.
Then we do that. And now we are on my patient, Annika. I mentioned her before. And one of our participants in the web seminars, Judith Harangoso from Budapest, used a nice wording for that was an expert by experience, that patients are experts by experience. And I think Annika is a wonderful example of that. Just a few words about my first meeting with Annika. She was at that time about 25 years student who has been a very good student, very clever, and had been in the United States for a year or a half. And she became ill when she came back to Sweden. And then she had relapses almost 2 or 3 times a year. And her whole life was spoiled. She couldn't move from her apartment, from her mother's apartment, so to say. And she had serious side effects of the treatment because one of her greatest interest in life was to play piano. And due to extrapyramidal side effects, she couldn't play piano, for instance. And her social function was greatly diminished. So she was becoming more and more alone with her panic attacks in the night and her mother. So when she was randomized to our research project, to the experimental group, that means that she should go into a resource group in the integrated care model. I told her, as I said to you before, about how the program was composed. She said yes, and the next thing that happened was that she got a new relapse. So she went to hospital for about 3 to 4 months, and then so the treatment couldn't start until she became a little better. As you might see from to the right in my screen anyhow, a short summary is that for Annika, my resource group changed my life in every aspect, so to say. So she has participated in some conferences, and in one conference she tried to summarize what has been the important thing for her being a part of a resource group. And one of the most important thing, you can see that at the lowest line, she had got an own team. She talked about my team of experts and family, and my team collaborates. Another aspect, this is quite independently of all research. This is just what Annika has found out 20 years later. She still meets sometimes with her resource group, but very seldom, because just in crisis or things like that. So here you can also see that empowerment is important in the perspective of the patient. And also respect for what the patient tells. So you cannot just say this is a symptom, or take a drug and then a medication, then it will work. And here we have, in Annika's word, participation. That's co-production, I think, being a collaborative partner. It was very interesting when we had Paul Batalden in the web seminars, because he was very fascinated by that Annika has found out this. She describes co-production because that also builds on trusted relationships and shared decisions. So when we first interpreted our data from the first 2-year randomized controlled trial, we thought that shared decision-making was one of the most important factors for the significantly improvement in the experimental group. There are rather few studies on shared decision-making, but agreements and shared decisions. And then the things can change. You have ability to change. Problem solving, the structuring of both problems and life. This is about 20, she wrote down this, I think about 25 years. I met her first. She had been very ill for, I think, the 90s, 4 or 5 years. And I met her in the autumn of 1994. So this, she wrote down about 94. It must be about 2016, because she lectured for a Dutch group that visited Gothenburg, and they were so happy of all she said. So she got the grant so she could fulfill her dream to visit the Netherlands. So she got the flight ticket, hotel, and people who guided her. So this is about 15 to 20 years after the start of the resource group management.
I think what is very important is the last sentence. My team of experts and family collaborate. I think this is the core element.
Yes, yes.
The whole effect, this collaboration.
Yeah, sometimes colleagues to me said when I once upon a time, I started my thesis doing group psychotherapy with people with schizophrenia. And some colleagues said it is a nice scientific research project. But Ulf, of course, you cannot sit there and talk with these patients because they cannot communicate. So how can you start a communication group therapy with people who cannot communicate? And that also gives you a little picture of how sometimes your colleagues are wrong, because they can communicate, and that has to do that you must listen, you must respect what they say, you must work it out together. I think she, in her own words, have summarized much of what the whole idea with research is, if it can be implemented and transformed into clinical practice. So nowadays, Annika, I think she meets with her doctor once a year, and she has a resource group. In the beginning, they met. The resource group met every month. The first years, she had lots of problems, I can say, that you could never solve with medications. And she also, when she recovered, got an opportunity to have, I think, 1 or 2 years of psychotherapy, working on the, I would today say it was trauma treatments regarding her when she fell ill in the United States. So now she lives in an own apartment, has a boyfriend, and have very little contact with a health care system. Well, how is the time? In fact, I
think our time is over. But if you have some
well, here I have my clock. You really, yes, yes, you're right.
Yes. But it's very interesting. If you have some final conclusions you would like to.
Here is something I just want to show you.
Yes, please.
It relates to the Learning Health Network. Philippe Delespaul is a Dutch psychologist who has been a member in the web seminars. And he together with a French group, they talk about an ecosystem model. And as you can see, he says what I just said: care does not fix the illness problem immediately, but it designs opportunities. And that the ecosystem environment should be the niche for resource group, and this interesting concept of citizen psychiatry. That is short. For those who are interested, you can of course have my slideshow, my PowerPoint slides. But we will talk. I think that Alexandra, you can fix that. So there is also an appendix that is secret. I will not talk about that now. It is about the tree, a knowledge tree that we just build on the earlier knowledge. Like a tree, there is rings in the tree, and what we have added is has a basis of many years of knowledge, but I will not talk about that. I will not talk anymore at all. I now found out that the clock was so much.
No, don't worry. I mean, it's all very interesting. It doesn't matter. We have the whole time is full, yes, but okay. So will we stop here and keep these main ideas and these main topics in mind? I included all the questions we had from the participants, so I think for the time being we are okay. And if somebody wants to read more, maybe we can suggest Paul Batalden and his article.
Absolutely. And there is a lot of references on almost everything that I have said. So for those interested, just contact me or Alexandra, so you can get lots of readings.
I think this whole discussion was very interesting because you gave the frame of the approach of how we can include practically patients in the co-production and how we can facilitate the equal participation of patients and family, and with respect and with really a more broadened perspective of care in the treatment and in the planning of the treatment. I think it's very important when all this is in accordance with extensive research and that helps people and colleagues think of it more and try to apply it. And I believe that this approach is filling in a way a gap in theory and praxis, because in theory I think there are much we know, but when we come to the clinical praxis to apply it in the everyday work, sometimes it doesn't work, and to have these models in mind can only be helpful and facilitate us to approach families and patients, not only through psychoeducation, where we must much work in Greece on that, but also with these other different levels of inclusion as we describe them. I think that on behalf of everybody, I'd like to thank you for this discussion and for this speech and for these very important ideas that you spread to the people who participated. And I will be honored to have you near to us and to have you accessible for articles or anything that the participants may need in the future. And I'd like, as a conclusion, to invite all participants to join the Greek branch of wapr through writing to wapr.gr at Gmail and getting more information on the organization, on webinars, on future webinars, and also on the spread of knowledge, like the knowledge and the research evidences that Professor Malm shared with us today. Thank you, Professor Malm, and thank you all for joining the workshop.
Thanks.
I think we can stop recording now and
So just a word to Alexandra. Can we have a follow-up meeting next week or something? You
yes.
and me?
Mm-hmm.
if you suggest that you're probably more busy than me at present for the next week, so that would be. I have a few questions about the availability of the recordings and also if people how we should do with the communication in the case people want to know more.
Yes, we can have. Now there are still people listening to us, so we can have it.
Yep.
We can arrange another Zoom. Yes. All right.
Stop share.
Ευχαριστούμε πολύ για την παρακολούθηση. Αντίο σας. Or Professor Malm, if you wait a moment that they get out and we can discuss about that now.
Yeah, okay.
But hold on a moment, please. That they are all out. Yeah. And because we are also in live streaming in